Welcome everyone, and thank you for joining us. I'm Holly Vossel, Hospice News reporter, and I'll be moderating today's discussion from CareXM about nursing innovations in home health and hospice. Just a little bit more about CareXM in this next slide. CareXM has provided innovative triage services and technology in home health and hospice since 2008. The company is purpose-driven, working with partners and thought leaders to transform and elevate the care experience for patients and clinicians. CareXM serves upwards of 5,500 providers in 49 states with more than 8 million patient interactions each year. All right, next slide here, and we'll jump into introducing our speakers today. Heading our talk is practice leader Kevin Childs. He formed Total Triage, now CareXM, utilizing the concept that when we replaces I, even illness becomes wellness. He's a technology and services executive who for decades has been relied upon by Fortune 500 companies and global heads of state alike. Kevin has set aside his serial entrepreneur status to focus as a practice leader for CareXM. Right. Also with us today, next slide, we have Jeanette Dove, whose 35-year love affair with hospice has migrated from spending hours charting and documenting home visits to her championing technology and service platform that would allow Bristol Hospice to expand its census up to 5 times without expanding headcount. Jeanette helped oversee the growth of Bristol to a census of over 5,000 and now sits on the Bristol Hospice Advisory Board after retiring in March. And with that, I will kick things off to Kevin, who will head off today's objectives in our next slide. Go ahead, Kevin.
Great, thank you very much, appreciate it. Okay, group, glad to be with you today, and I appreciate the invitation. The objectives we're gonna review today is really to, first and foremost, to hear, acknowledge, and interpret the challenges of home health and hospice organizations, where we've been in it as an industry, where we are now, some of the changes that we're dealing with specifically in hospice, and where we have the ability of going. Jeanette, a very dear friend of mine and confidant, who's been an advisor for what we are all about for many years now. She's going to be joining us in this discussion and talking about some of the specific successes that Bristol has seen as they've grown. A little bit about me, just a full disclosure, I'm not a healthcare professional. I'm kind of masquerading as one. My entire career has been in the customer interaction space, where we spent a couple decades building processes, practices, and technologies that have helped organizations to really enhance the overall experience that their customers have as they interact with specific companies such as an American Express, a Marriott, a General Motors, and others. We've consulted organizations from St. Petersburg, Florida to St. Petersburg, Russia. And about 9 years ago, just a little bit about me, about 9 years ago, I became a late stage colon cancer patient. And 2 years, the 24 months prior to me becoming a cancer patient, I had lost 3 very good friends of mine dating back to my childhood, all to cancer-related deaths. So when I got cancer, my life sort of changed dramatically, and I kind of stood at attention. This particular picture right here, you've heard that pictures are worth a million words. This picture really defines the look on a nurse, a home health nurse that was in my home, unhooking my chemotherapy port after my 5th chemotherapy treatment. I'd been on chemotherapy for about 56 hours, and she came in to remove my port. And just as she had prepped herself to remove it, her phone rang, and she was pretty frustrated. And she looked at me, and she stepped away and took a call from another patient. And as soon as she resolved that particular situation, she came back to my bedside. And just as she now got prepared again, the same thing happened. Her phone rang. She had to step away. And I witnessed firsthand the difference between what corporate America, how they sort of protect employees as well as consumers as they're calling them. So we started a journey at that point in time, and I relied very heavily on my good friend Jeanette Dove, because what we wanted to do was remove this level of frustration away from nurses and enhance the overall experience of patients. So the big question in the home health and hospice category that we've learned since then is, can they ever get a break? Certainly in the world that we live in, they're primarily focused on helping patients either navigate end of life experiences, or in my case, a really sensitive recovery. And at this point in time, as an organization, we have really committed ourselves to helping companies address those particular needs. Certainly recognizing that when we lose nurses in our space, it is very, very costly, not only to our organizations, but and the relationships that we drive with our patients, but it's very costly to start over again. In support of that, we've got the Institute of Healthcare Improvement, IHI, and they've really focused on the quadruple aim over the past 2 years, certainly since COVID, in how do we as providers elevate the overall experience while we reduce costs and protect our clinicians and the patients. And what we have found, certainly in working with a lot of home health and hospice organizations, is that the minutes and the moments really matter when it comes to a patient interaction. We're all familiar with the survey that we participate in every year, and 7 of the 8 questions that are the primary questions that are asked certainly have to do with timeliness. Can they get a hold of us? And how organizations respond to those minutes and moments. Now, the reality is my experience in the non-healthcare space, working with these large organizations that interact with customers, they recognize that this gray line here will represent call volume, and the orange line represents how many people you have actually available to communicate with your customers as they call, customers or patients. And most organizations strive to align resources directly into call volume, but that's a very difficult thing to do. Most organizations know that if call volume is really low, they're going to be overstaffed. But in the event that call volume is really high, but they don't have enough staff available, in my case as a patient, that nurse had to step away from my interaction to address another issue. And there was a deficit specific to the needs that particular nurse needed. So the ideal for an organization is to find the equilibrium point, how to align the right resource at the right time for a patient's need. Now, unfortunately, a lot of organizations have tried different things. I'm going to refer back to a childhood story that I loved when I was younger, the 3 Little Bears. And it was either too hot, too cold, or just right. And that's what we're all about today. We're going to be talking about how do we find just right. Now, in the past, a lot of organizations have said we're going to figure it out on our own. We're going to just keep adding more and more staff to address our call volumes. But a lot of times, once they start peeling back the financial onion, they recognize that the recruitment, the training, the people, getting the right kind of technologies in place, that can be wildly expensive. So you have to look for a different path. Now, the different path is heavily influenced based upon how many people you have working and aligned to your patient interactions. Now, most organizations in the non-healthcare space, they have, if they have a lot of volume, they have a lot of people in their triage units or customer service departments to where they can drive high levels of productivity. Where on the other end of the spectrum, you take healthcare. Certainly, these are non-call centers or triage groups. These are just offices. Here in the United States, there's about 15,000 home health and hospice offices, individual offices, and you're going to find anywhere from 1 to 9 people sitting in those offices, depending on the size of the office. And unfortunately, if you are small and you have 1 to 9 individuals, the data would suggest that you're only running around a 29% productivity rate because you're not able to find that equilibrium point. And subsequently, it drives a much, much higher cost onto the organization. Now, as we've spent really 2 decades in the customer experience arena, we have found through our research and studies with Purdue University, we have found that only 10% of all companies, all organizations are able to drive performance into what's considered the upper right-hand quadrant, where you drive high quality at a really, really efficient lower cost. That's where you track first call resolution, how quickly can you answer a call, what do your patients or customers say about their experiences with you. When you do have them on the phone, are you able to reduce talk time and get to the matter very, very quickly, and at the same time reduce the overall turnover? Only 10% of companies enjoy that, while 50% live in some type of deficiency. We call those the sick puppies of the world, where you've got people, process, or technology challenges. So a lot of companies have said, since I cannot get to the upper right-hand quadrant, and I seem to be living in the lower left quadrant, I'm going to just move all of my customer interactions to a third party. Those would be third-party triage companies or non-clinical answering services, where they step in and say, we commit to be able to deliver, to recruit the right people. We're going to train them to communicate with your patients the way that you would want. If there's ever turnover, we're going to address that. And going back to the three little bears, this becomes too cold and too costly. So what we have recognized in our research outside of healthcare and now inside of healthcare the past 8 years is there's a lot of challenges when you give up control of a patient interaction to a third party. Now, if you look at our non-clinical experience going back, you'll see some of the largest brands in the United States that have attempted to outsource a large portion of their customer interactions, just to find that their customers turn around and express high levels of dissatisfaction. Putting it into the overall grade category, a D+ is not what organizations would really seek for. So if large companies can't figure it out, how can small and medium-sized home health and hospice organizations figure it out themselves? When you end up throwing your interactions to a third party, a lot of times you'll end up painting yourself into a corner that becomes very, very difficult to get out of. So what we've discovered over the past 8 to 9 years in partnership with organizations that really Jeanette has led over the years is the best thing to do for an organization is have flexibility. Outsource or insource non-core components. Build your teams up, support your teams where you can, but in the event that your call volumes are higher than you can handle at that moment in time, let's say 2:15 in the afternoon, you may have a really long hold time and you'd want that patient to get interaction. Partner with an organization that can deliver people only when you need it. Partner with organizations that have been there, done that, that can help you improve your internal processes when it comes to patient interactions. And then where they've built technologies that can have a positive impact on your person, the nurse, and your person, the patient, leverage those technologies while you as an organization can retain control over your complete patient engagement strategy, the full clinical leadership of those patient interactions, and the the end result of patient experience. So we blend, as an organization, we promote the concept of blending in-person care with technologies, where you have clinical or non-clinical backup, where you can deploy technologies that can help you understand how well is your patient doing, even when they're not calling you, promoting virtual office visits, and then scheduled or unscheduled interactions, looking at the trends and the way that you can evolve those particular outcomes. We call it the XM experience. The XM experience is all about taking a patient, like I was a patient, and giving them an experience similar to what they had in the hospital. They had the nurse call button in the hospital. It went down the hallway to the nurse station, and within 30 seconds, typically under a minute, you're going to have a nurse bedside to identify what your challenge is. When you go home, you're now educated during the intake process to dial this telephone number. Well, what we sought after was the answer on how you could take that telephone number and make it look and act like the nurse call button within the hospital itself. And we call that CXM. So that telephone number that you deliver to an individual, you have the ability of pointing it into an infrastructure that is interacting with the EMR itself. So when the patient calls in, it says they're hearing, "Thank you for calling ABC Hospice Organization." On the back end, the system's saying, "Hey, EMR, do we know who the caller is? And do we know who the case manager or appropriate on-call staff? And are they available?" Where an extension of CXM would be a mobile app that says, it basically looks just like the phone within your smart device, but in this case, the phone delivers state management, lets us understand, is that nurse or on-call staff member available? Green light means go, red light means stop. In the event that they're unavailable because they're in front of a patient removing their port, their phone is not going to ring. Instead, it's going to be routed directly back to the client intake or triage group, or it could go to the CareXM nurses, registered nurses, 100 plus of them across the country, who then can collaborate with the on-the-ground runner or visit nurse. Or it could go, if it's a non-urgent call, it can dynamically be sent to a patient advocate. And the last thing it can do is take remote patient monitoring capabilities. Something as simple as my Apple Watch, we can understand the nature and care and custody of that patient. That is what we call the CareXM experience. And really, it's really just, it's broken into pieces based upon an organization's current challenges. Now, I want to just pause really quickly and give you a snapshot of what another set of partners within our world, which are the Providence operations up in Washington and Oregon. So I'm going to just click on this, let you hear a little bit of their experience of the CareXM solution.
But having the nursing background and having a nurse the first time you call answer the phone to help with symptoms immediately has made a significant impact on the care that we're able to provide to our patients and families. And the continuity of communication then back via the report portal, and we're able to see what happened all day long, in addition to the layer of support that our call center internally provides. It has significantly improved our communication scores.
Our scores went up 10 percentage points within a year. That's crazy. That doesn't happen.
You can see how many calls we're getting around end of life, the amount of refill requests we're getting after hours, how many patients need help with symptoms, or if there's a DME issue, and being able to have the ability for that transparency to go back and then work directly with the staff and put action plans together that flow up to our quality plan. Like, it's just so the transparency just allows for us to really tackle what our true problems are.
Okay. So that was it gives me a lot of joy when I can hear individuals that have been able to leverage certain pieces of our solution. Now, again, it's not a one size fits all. Some organizations just need us to have our nurses step in and back them up when they need help. Other organizations say nights and weekends. Other organizations say 7x24. Other organizations just need the technology and they don't use any of our people. So the nice thing that we've been able to deliver to organizations is really just a menu of options based upon what their actual needs are today. And those needs can change over time. And one of my experiences in this scenario was working with Jeanette Dove. When I was a patient, I needed to figure out how you could take 2 decades of customer experience that I had had in the non-healthcare environment and translate it directly into healthcare. So much of what we look at today within our world has been heavily influenced by Jeanette. So I'm going to pass the baton to her now.
Thank you, Kevin. I just love hearing the CareXM story every time I hear it. It just makes my heart filled with joy. But I'm going to talk a little bit today about our healthcare environment as a whole and about our friends at CareXM, and throw in, as you can see from this picture, a little blast from the past. So it'll be interesting to see how many of you can pick up on those as we go through. But I think we'd all agree that the challenges are abounding out in the healthcare field today. And it's not just the post-pandemic world, but it's the wider socioeconomic and demographic arenas that we deal with every day. Sometimes due to the great resignation that's happened in the staffing shortages, we, our clients and our referral sources, feel the pressure of trying to find hospice and home care for our patients and families. It's interesting that hospital discharge planners are reporting that they call 42% more home health and hospice agencies per patient to find a provider that can accept their patients. And on top of that, our nursing staff are seeking employers that are focusing on work-life balance, technology efficiency, and quality patient outcomes. So all of these market pressures point us to as the Beatles would say, that's a hint, we need a little help from our friends out there as we go forward. Just a quick blurb about me. I began my early career in critical care nursing back in the halls of the Houston Medical Center. And I became quite disillusioned with seeing our patients and families separated during their end of life experience. Kevin, can you go to the next slide?
Yep.
And this led me to searching for a nurse specialty that focused on quality and the patient's end of life experience. And that's when hospice nursing became my professional passion. I'm kind of dating myself as you look at my three pictures here, because these guys were my trusty friends when I was an early hospice nurse. My car was my office, a Ford Tempo, I'm sorry to say, my pager, and a relic from the past, a payphone. I'd hear that beeper go off. I'd be driving around the streets of Houston, searching for a payphone, rummaging for the bag of quarters that I kept in my car, and then fighting the weather out there to get on a payphone and get a hold of a doctor or a patient with all the noise in the background. So it was an interesting time. So my car, my beeper, and my payphone were my communication trifecta in the nursing world at that time. And they helped me meet the day-to-day needs of patients and families. But I dreamed of more out there. I dreamed of more technology. And technology was in its infancy then. Next slide, Kevin. For those of us who were delivering hospice care out there in the community, we dreamed about that electronic medical record system, but technology was slow catching up with us, with our dreams. So during my years of working in hospice leadership, I retained the dream of making the hospice experience better. And then, as Kevin said, I met him. And he shared his story with me and his vision about where technology could go and how it could help us as hospice and home care providers. I knew that Kevin was that person the universe had prepared that we can live out our dream together. And so we went to work, and we've had a lot of fun doing it. Next one, Kevin. We all know hospice and home health is changing, and one thing we can count on for sure is it's continually changing. We have to be tough, and we have to be fast on our feet. What it comes down to, all the things that Kevin's talked about today, is that we as managers have to put the right nurse at the right time in front of that patient at the bedside when they're needed, and that they have to have undivided attention for that patient. And that could be now in today's world, either in person or virtually. So that's where some of our challenges are starting. We do have some other challenges and pressures from the outside. Next one, Kevin, please. You're going to recognize these 5 stars. We are going to have 5-star rating come up for us and become public as a hospice providers in August of this year. And as a quick review, the stars range from 1 to 5, going from the worst to the best. And they're calculated based on your top box scores from the 8 hospice CAP survey measures. This is great for our consumers. It provides a simpler way for them to understand the caregiver experiences and apply that to what hospice provider they want to use. It gives them, empowers them with the tools to find a great hospice provider. But it also gives transparency to the hospices. And by doing that, which is a good thing, but it increases the pressures of the delivery of hospice care upon us. So those changes are going to affect us every day. And not only the 5-star ratings are going to affect us, we have the HOPE assessment coming up. It's a change factor that's going to affect us. It's the Hospice Outcomes and Patient Evaluation Tool. Next one, Kevin, please. It gives us standardization of the care that we're providing out there as hospice providers. And it'll give CMS an insight into our day-to-day hospice care that we're delivering. It allows them to analyze all the data, pick up on our data patterns and trends, and help them identify the differences between hospices. So what are we going to need to help us? We're going to need technology and business intelligence solutions that are going to become more vital in our everyday delivery of hospice care. And we're going to definitely need some help from our friends. We're going to have to really focus hard. Next one, Kevin, please. Because with these regulatory changes, staffing pressures, operational puzzles that we're going to have, and organizational growth expectations, our vision becomes a little bit blurry, and we need something that is going to help us focus on what matters most. And so what do we do? Our next slide shows us and gives us some hints of what we can do. Business intelligence and nursing productivity are going to be essential to today's hospice and home care manager. And there are some musts that we must do out there. We must demonstrate fluidity and continuity of the hospice care experience. We must be the very best at delivering that experience 24 hours a day, 7 days a week. And as Kevin mentioned, we have to be on our feet, agile and flexible. And to do this, we have to have our friends to help us, and we have to use business intelligence. This is going to allow us to win in our space, and most of all, delight our patients, delight our staff, and yes, even delight ourselves as we deliver our work in hospice care and home care out there. The next slide shows me also was going to be a little blast to the past. I'd like to share with you a little time that I got a little help from my friends. As Kevin mentioned, I was serving as an executive vice president of clinical quality for a large multi-state, multi-program hospice enterprise, and we were fortunate to partner with CareXM. During this partnership, I was able to see that futuristic world I hoped for of technology in hospice care and home care use business intelligence in a way that I only dreamed of. Let's talk a little bit about my friends at CareXM. This next slide is going to show us a little insight into what we did. I want to take you back to a time which probably was just a few minutes ago for some of you, when you experienced that moment of terror that you realize you don't have enough nurses to meet your patient needs, whether it's for the next hour or the next 24 hours or the next week. You get that feeling of desperation and panic. And the first thing we typically do as managers is we start sending out those texts, emails, phone calls to all of our staff and all of our managers, and we say, help, we need somebody. We start using our emotions and try to use our intuition to work these things out, to answer our questions, to help us find what we need. And then we end up calling HR and ask them, why aren't we hiring people? We need to hire. But then on the back end, we know when those nurses come into us that we hire new, we've got to train them. We have to determine how long it'll be before they're independent and can provide care with a patient on their own. How long before they can take call? And it goes on and on and on. This is when I turn to my friends at CareXM. The business intelligence suite and the reports in the portal help me achieve proactive and innovative choices to staffing support and patient services. My ability to be able to dial staffing up or dial it down based upon who was my backup nurse or my primary nurse or how many staff I had and how many offices helped to neutralize that terror that I felt and remove my underlying day-to-day woes and fears about staffing. I'm going to share a little bit in the next slide about some of those metrics that we used that gave us some definite insight to help us on a day-to-day basis. This graph is an example of some of the data that we brought together to assist us in projecting staffing needs and understanding patients' needs and our own needs. On this slide, the pink and the red represents the call volume or our unscheduled patient interactions on a day-to-day basis. The light blue is our peak call time, usually right after the office closed or right before the office opens. That was a definite dynamic we learned from this. That's when a lot of calls come in, so we need some staff to manage those calls. And the dark blue was our overnight incoming calls. Using these reports over time, we could accurately predict the staffing needs based upon the day of the week, the time of the day, the clinician, by the office, and by our enterprise as a whole. We begin to find ourselves working smarter, not harder. The next graph tells another little story. We began growing our business while we were managing during the staffing shortages, one of the challenges we talked about earlier. It's a little busy slide, but I want to show you how we used the business intelligence to help us get our day-to-day insights. The blue line on this slide shows how we were able to dynamically pivot and route the patient's unscheduled calls to the right person at the right turn the first time. Thus, we achieved first call resolution, the holy grail that we all look for. We were also able to ensure the calls went straight to who they needed to go to. They went straight to the nurse who was caring for that patient during the daytime if they wanted to take their calls, or it went straight to the after hours nurse who may have been assigned to that group of patients. So we were able to direct those within minutes and do the pivot on a dime, as I like to say, and get our patient calls to the right place. We knew that based upon staffing and nurse availability, we had some locations that sometimes took 100% of their after hours calls, or we looked to our friends at CareXM and took advantage of their nursing staff being able to staff our calls virtually. The most important summary from this slide I'd like to go over is that the data set we were able to pull gave us the insight into our staffing every moment that we had calls coming into our hospice. We were never staffing in the dark. So that was what gave us a great sense of calm and peace, not only to us as managers, but also to our hospice nurses out there in the field as well. They knew they had the support that they were going to need, somebody to take that call if they were at the patient's bedside, like Kevin explained in his case. So we got greater patient satisfaction and greater peace and calmness among our nurses delivering care out there. The next slide shows a little bit about our insight into education in our staff and how we were able to do that and individualize that. The business intelligence tools that CareXM gave us allowed us to identify custom metrics, as you can see in this one. It told us that we got first call resolution, but it told us which programs and which case managers were actually achieving in compliance with that first call resolution. With this data group, we were able to go to the hospice location itself or directly to the nurse to assess their need for additional education, or which nurses and which locations were our superstars that could become our mentors, and which locations were our superstars for us to recognize and share and celebrate for the good and excellent care that they were giving their patient and family. All of these metrics became an integral part of our quality plan and our improvement initiatives, not only at the location level, it helped at the regional level and as the enterprise level as a whole. So we were able to have an insight into what was going on every day in our locations. One last slide I just want to share with you that I'm really proud of. This slide you see in the green line shows that we grew substantially during the time that we were doing all of this. And it is over a good time period from 2018 to 2022. We were able to decrease our number of after hours call from 2.5 per patient to 1.2 per patient per week, a 50% decrease by effectively utilizing the business intelligence and metrics and quality improvement measures that the CareXM portal gave us. We met the patient needs on the first call, which resulted in fewer follow-up calls, and which in turn resulted in nurse satisfaction and patient satisfaction. We developed staffing agility, I like to call it. It became a reality, and we improved nurse productivity, and we enhanced the bandwidth of our nurses. So you can see why this is one of my favorite slides that we worked with in our company. The next slide shows a little bit about what Kevin talked about, how the app looks to our nurses. It streamlines our operations. It's easy to use, easy for the nurses to click and see and customize to the needs of your organization. It improves efficiency. It empowers the nurses. And one of the most important things is the metrics that you are using in your quality initiatives come directly from the nurse themselves, putting this information in to this app. So when a nurse says, I don't think that's what happened, you have it directly from their horse's mouth. You could say, this is directly from what you gave us as a nurse. So it gives you some real direct tools that you can use on a day-to-day basis. Next slide. Thank you, Kevin. I love this picture. I love it because it truly embodied the way that my teams came to think of the CareXM team. Not a separate organization, not a separate team, but we were together. We embraced each other's goals, each other's partnership, and it was all based on the care of the patients and families that we delivered to them in their home setting. I like to say that we embrace the heart of healthcare together. So I just really, really enjoyed looking at this slide. And that leads me to, so what's ahead for all of us? I think after seeing the results that I talked about, you can be optimistic. Optimistic about the future, despite the challenges that we have in front of us. The silver lining that comes from the chaos we've gone through over this pandemic is that the general public, the industry, and yeah, even our regulators are coming to the conclusion that we can blend in-person care with technology, and it doesn't have to make healthcare impersonal. And I'm so excited that at CareXM, there's an opportunity to do that blending together with a company and make the patient experience the most excellent experience they could have in the healthcare setting as a whole. So I'm honored to have been able to share a little bit today with you about some outcomes that we have. And thank you, Kevin, and thank you everyone for joining us.
Yeah, thanks, Jeanette. So Jeanette, if I can, I'll just, I'm going to jump down one more slide and then I'm going to go backwards. CareXM, we just started with the idea of this concept of first call resolution. That concept has been in corporate America now for years and years. Nobody likes to be put on hold. Nobody likes to hear I'll page them, going back to your communication trifecta. Nobody likes to wait, especially in the healthcare category. I remember my first chemotherapy treatment. It was around I'd had the pack on me. It was a backpack of chemotherapy, and it was at 2 o'clock in the morning, and I called Huntsman Cancer. And nothing at the end of the day. It was just my emotions and some of the challenges that I had of what I was feeling having this treatment. But you do have to have someone call you back in the past anyways. And today, that isn't necessarily the case. Going back to this slide right here, you'll see here 5 or 6 down, you have one particular location that it took 78% of their calls in a first call resolution. And since they couldn't take it, they took the calls 78% of the time in Q1, and then it was 71% in Q2, and things happened, and your team needed to come out of the queue per se, and our staff picked up the slack for that particular organization for 2 quarters while they were reshuffling staff.
Right.
And then down below, 4 from the bottom, this particular location, where we used to take 100% of their calls before they started using some of the tools, they are now consistently in the 90s. I'm proud of the fact that our nurses triage, and about 60% of the time will address a patient need. And if they cannot address that patient need, it's going to be warm transferred to into one of your nurses. But can you talk for just a minute about an organization that once had us take 100% of their calls to where they're now doing first call resolution directly with a case manager or on-call staff? What did they have to go through in their mind in order to go from us to 100% to them now over 90%?
Absolutely, Kevin. We found, depending on the organization or the location, it was just like that. The nurses said, I want to take my patient's call. I want to do that. But there were other organizations that are locations that said, you know what, maybe I'd love CareXM taking everything. So we had to really customize that education experience in regards to helping those nurses find that balance. So what we did was a lot of education, and we came to find out that as we did that, the hospice as a whole, the organization as a whole, the nurses came to understand the importance of using our nurses to take that first call. They saw those patient satisfaction scores and the connections after they went out and visited with the patient and family that happened were so genuine and so beautiful that they came about and turned around to that 90 or 98% of answering the calls to our call nurses being the ones to being the first responders. But let me emphasize as well, our nurses knowing that the CareXM staff was there in case they were with a patient, as you mentioned, or in case they had to step away and sleep some, was the peace and the comfort that our hospice nurses gained by knowing that that continuity was there, and they knew our patients as well. But it was a little bit of a change, a little bit of a challenge. But in the end, as you can see from the numbers and the graph over that 3-year period, it definitely improved patient care. It definitely helped us grow our census. And we saw nurse satisfaction as well.
Yeah, that's amazing. That's awesome. Finally, one other question. In the beginning, we didn't set out to, it was kind of a little bit of a cherry on top for both of us, but we didn't actually think that the data was going to help us reduce interactions, as these unscheduled interactions. But if interactions are reduced by 50%, how much more capacity does that nurse have? When I say that question, it's more of an emotional capacity. If you're removing work and taxation off that nurse and giving them 50% of their life back, what does that mean when it comes to the concept of turnover within your world?
Well, it was a huge thing in that we shared this during our recruitment and retention pieces for our staff. When we recruit a nurse, we shared that we used CareXM after hours when needed to have that support. But we also shared this information after we realized that cherry on top as well, that without affecting patient satisfaction, in fact, even making it better, we decreased the number of after hours calls coming in from our patients and families through really focusing on education during the daytime and really putting the nurses first call up front when a patient does call at the forefront of what we were doing. Yeah. The warm transfer you talked about, Kevin, we never had anybody hang up and have to call a patient back. There was a warm transfer from CareXM if they answered the phone directly to the nurse. So we never took our hand off of the patient's shoulder. And that's the one thing that I really feel reduced these number of calls, was that we always had our presence there with the patient as they were going through this.
That's great. Thank you, Jeanette. I'm going to jump down to and sort of pass the baton back to our good friends at Aging Media. We're happy to open this up for Q&A if you'd like to facilitate such.
I'm sure. Thank you both for those insights, providing them, Jeanette and Kevin. I think that right now we're just going to jump over and address a few follow-up questions that we have. One is, what do you feel is going to be the biggest challenges and changes on the horizon in home care and hospice in the next 5 to 10 years? Jeanette, you want to take that one?
Sure, absolutely. I think the biggest challenge is going to continue to be exactly what we're seeing right now, is keeping our nurses in the hospice and home care setting, staffing our patients' caseloads very well, not only with nurses, but with the home health aides out there. We're also seeing that it's hard to get nurses and home health aides. So being able to bring nurse satisfaction, being able to improve patient satisfaction helps us keep the nurses out there. So I think the biggest challenge is going to be over the next 5 years, bringing more nurses into home care and community nursing.
You know, I'm not a
valid point.
I'm
Yeah,
not I'm not a clinician, but I do see the data, and it's pretty shocking that in the past 6 months, 30% of all nurses that have quit, that have left their positions, have actually decided to take a pause from their profession. That's a pretty scary thing.
Yeah. And I know Hospice News, even in our coverage, we reported a lot about different sides in the clinical and non-clinical side of it. So that's a good point, Kevin, that it's a lot, it's widespread and it's massive, and it's definitely something that's an issue on the top of a lot of providers' minds. Okay, we have, next is a question. You guys were discussing this a little bit in the webinar, just how calls are really fielded within that solution system. You want to just get into the nitty-gritty of how do you take all the calls? Are some of those addressed, and maybe how fast these are answered and addressed?
Yeah, I'll just go right back to that slide.
Sure.
CareXM is really a very sophisticated routing solution that is able to compare a patient through an interconnection with the EMR, the level of service that the patient is on, and then making a determination who would be the best person to speak to that patient who is currently available. So some organizations, such as Jeanette's, when they rolled the technology out, they said, we're going to go from relying on CareXM taking 100% of our calls to taking what we can. And they actually started with the goal of 35%. Let's just start using the tool and see if you can do it. And in most cases, the adoption was really heavy. And by the second or third year, they said, now let's see if we could actually take 70% of our calls. So the system itself is going to route calls based upon the availability of a resource. So the slide we just saw a few minutes ago, where different locations had different percentages, it's really driven off of the particular need of an organization. I'd say about 30% of our customers still have us taking 100% of their calls, 100% of the time, which we're happy to do. We certainly will always recommend along the way that since we can take 60% of all calls and resolve them, there is 40% of the calls that we have to do a warm transfer to. So the technology is really aligned with the resources and goals of our customers. It enables that to happen.
Right, sort of allows for that supplemental help. Yeah.
And I'd like to say too that during that time you're transitioning, as Kevin mentioned, what we did, the support and the guidance that we in partnering that we got from CareXM was just amazing. Like I said, they become our very best friends, and were working with us on a day-to-day basis. So you're not doing it alone. Definitely partnered.
Yeah.
Right. especially when those staffing resources we just mentioned are pretty thin. So,
Yes.
and I think our last question for today, I don't see any more coming in, but how do providers, how would they drive down the varied demands from patients and their loved ones while also, working to improve that delivery of care?
I'll take that one, Jeanette. I'll
Okay.
start out with the tool itself. There's this concept of dispositions, and the EMRs today don't really give you the ability of understanding the interaction. It just is the medical record. Our tools help us disposition every single interaction. So when a nurse is using the tool and they finish that interaction with the patient, they're given a pop-up and they just hit a button that says they called for medications, they called for X, they called for Y. And there are a lot of different reasons that patients call. And through the data, through the gathering of the data, which happens immediately after the call ends, that data is then presented the very next morning through stand-up sessions within the locations, to where it changes case management on a daily basis based upon what the data is suggesting. Jeanette, do you want to add or subtract to that?
You're right on target. Our clinicians during the daytime could address the needs that came up after hours with their patients right away. They could see that, when they open up their app in the morning, they could see that. So it gave us the tools to really be proactive on a day-to-day basis. And that is what resulted in good patient satisfaction.
And I think just a follow-up on that, just how does this solution sort of work to reduce any strategies in bringing down those expenses and overhead for hospice providers? When it comes to cost, how are these helpful? Kevin, I think that might be good for you to kick off.
Yeah, I'm going to go back to this slide right here. This is the reality that all organizations deal with. They try to guess when a patient has a need, and then they start overlaying people into that scenario. What we traditionally find with an organization, once they deploy the tools and the data, they're able to redeploy resources into different aspects of the business. You don't typically lay anybody off. It's just a redeployment of the resource to where you're able to get really align your resources with the patient need, and to get to this concept of the equilibrium point. The single most expensive aspect of our business are really people costs. So if you can deploy the people when and where you actually need them, and then pull them back, then in some cases we have customers that have full-time staff on the clock 7/24 before they do business with us. And in many cases, they're able to just shrink the hours that their staff has to work, because we'll step in during the valleys and replace it with an incremental on-demand charge instead of a full-time headcount sitting there working from midnight to 8 a.m. as an example.
And Jeanette, anything to add on to that, or did he sum it up pretty well?
He summed it up pretty well. I can just add that we were able to do that in many situations and customize it. When we had startups where we needed the phones answered, and we had one staff member that worked the nighttime shift, that was present in that location. Or we could have, they took the calls completely. It was just the flexibility and the ability to pivot where we needed in regards to that gave us and impacted our bottom line in a positive way.
I'll add to that. I was on a call maybe a month ago with a pretty senior executive at Kaiser Permanente, and there's a lot of research within that particular organization. They said whenever we hire, we have to hire in whole increments. You hire a full-time nurse. When you do business with a CareXM, and you align your needs particularly with this type of capability, we are in the fractional staffing business. Organizations, when they do business with us, don't have to hire in whole increments as they grow or they shrink, because we step in with fractions of a resource instead of a full-time resource.
Gotcha. And that kind of translated into staffing costs, that sort of thing. Yeah. Okay, well, that makes a lot of sense. I think that was the last one that we had on our docket, and I don't see any more, so I think that will wrap us up for today. Thank you again to Jeanette and Kevin for joining us, and everyone tuning in. We hope you take care and enjoy the rest of your day.
Thank you very much.
For now.
See ya. Thanks, Jeanette.